My name is Maria Weiner, and I'm the president of Florida Caregivers Network. So I am so ready to start this day. I've been ready for the past 7 months.
So have we.
Yes, ma'am. Good morning, everyone, and welcome to the second annual Caregiver Conference, Getting Real About Reality. Today will be a special day for all the caregivers in this room and professionals that care or know someone that lives with dementia. I hope that by the end of this day, you guys are re-energized with all this information we're going to give you, have the tools, have all the resources for you to take care of your loved one. So we're going to start, and we're going to get real about reality. Jessica Banko, Dr. Jessica Banko, I'm so honored to have her here today. She is an Associate Institute Director and Chief Operating Officer of USF Health Bird Alzheimer's Institute in Tampa. Dr. Banko has over 15 years of experience performing translational research, directing research administration, managing multidisciplinary healthcare clinics, and developing education programs for graduate students, healthcare professionals, and family caregivers of persons with dementia. Please welcome Ms. Jessica, Dr. Jessica Banko.
Thank you so much. It's a real honor and pleasure to be here with you all this morning. I was coming from Apollo Beach, and I was concerned that the bridge might be closed due to fog, so I came the long way around, and it was the real long way around. Let me make sure this. Okay, super. So I'm going to do my best. I didn't realize I was going to be on split screen, so I'm going to do my best to be able to highlight things that I want to call your attention to on some of the slides on both. So if you don't mind me walking back and forth a little bit, I'll be happy to do that. I was having the honor of being one of the first content experts speaking to you today. I wanted to give you a bit of a primer. I know some of this may be review for you and kind of refresh and dust the cobwebs off of knowledge you may already have about Alzheimer's disease. For others, it may answer some questions that you've either not realized you have or haven't felt comfortable or found the right person to ask them to. And so hopefully it will accomplish that. And then give you a bit of a context for what you're going to hear the rest of the day. Hopefully, as you go through the talks the rest of the day, particularly those talks that are addressing how to effectively communicate your feelings and get the feelings of your loved ones in return, how to make sure that you are optimizing their day, engaging them in their activities of daily living. Perhaps it's you or them managing undesirable behaviors. Hopefully this will give you a bit of a context of why those things are happening in the first place to your loved one, and help you understand why some of the tools and the techniques that you'll be learning about are important and why they work the way that they do. Finally, and the reason why my talk is Alzheimer's 2020 is because we always look forward in this disease, we never look backwards. And there's so much on the horizon to look forward to, both for all of us in the room that are living with it in some capacity today, either through a loved one or ourselves, and for our children and grandchildren coming. It's going to be a very different frontier, Alzheimer's disease, that they're looking forward to, and it's not one that I mean to scare you by. It absolutely, the whole bottom half of my talk is going to be hopefully one that inspires you and gives you a lot of hope for what 2020 is going to look like. Now, let me make sure I get forward and not backward. I think I have to turn around to do that. Okay, super. Okay, so these are the statistics, and I'm not going to go through them and paint the pale picture. We all know that it's a pretty pale picture. Particularly, why do we have an Alzheimer's Institute dedicated in Florida? It's because 1 in 40 of us are dealing, like we all in this room are dealing with Alzheimer's disease. It's not only a global disease, but right here at home, it has such a devastating social, emotional, and economic impact, because we have such a wonderful state. Everybody wants to spend their golden years here, and then they get sick, and so they're living through the daily drama of Alzheimer's disease in Florida as well. So much of what we do at the Institute is not only taking care of those families and those patients, but it's training the healthcare providers in how to better take care of them. Not just our healthcare providers, but those, many of them in the room have had training and education from the Alzheimer's Institute and other places like Alzheimer's Association to do a better job and to specifically learn the skills of how to improve the quality and the safety of care for people with Alzheimer's disease. That's because it's the 6th leading cause of death. It is claiming as many lives a year now, nearly as cancer and heart disease do. So one of the things I want to start with is understanding the biology of Alzheimer's disease. And I don't mean like you're all going to leave with a test or a PhD in neuroscience. It's not going to be complicated like that. But the reason I want to talk about it is because so many times one of the first questions I'm asked as a family member or as an early patient is this going to be my legacy? Is this what I'm going to leave my children and my grandchildren with? Is it Alzheimer's disease? Because I have it, are they going to get it? And that's a really important question. I understand it's an emotional question for many of you, and there isn't an easy answer to it. Most of the time, the answer is no. The answer is no when you haven't begun to experience your symptoms until your very late 60s. This is a form of Alzheimer's disease. It's the most common. It's probably the one that the majority of us in the room are familiar with. It's called late onset Alzheimer's disease, and you begin showing symptoms after the age of 65. Now, this is the form of Alzheimer's disease that we do not believe is primarily inherited from your family members. This is the form of Alzheimer's disease that you have the greatest risk of developing solely on how many birthdays you enjoy. More birthdays you enjoy, this becomes a possible consequence. At the age of 65, your risk for developing the features of the brain that we call Alzheimer's disease starts to increase. They increase because the proteins in the brain start getting naughty at that age. And so at 65, you have a certain amount of risk that if you continue to live, you will develop Alzheimer's disease. Every year thereafter, that risk increases. So when you're at the age of 85, 1 in 2 to 1 in 3 of us will probably have Alzheimer's disease if we live that long. That isn't because mom or dad or other family lineage had it. It's because we are that age. It is the highest risk factor for Alzheimer's disease. There are things we can do to mitigate that risk. There are also things we could do to add on top of that age risk, and they are related to our lifestyle habits and our environment. So we do know that abusing drugs and alcohol, we know that living a sedentary life, not remaining actively engaged in life, whether it be socially, everybody talks about, playing your Sudoku and doing your crossword puzzles. Those are important. They're absolutely important. But I mean being engaged in life all around, being socially engaged, participating in your card clubs or your dinner clubs. Maybe it's being musically engaged, just banging on the piano or picking up a guitar or trying to do something new like that, taking an art class, even if it's an art and wine class. As long as it's not too much wine, it's okay. But the idea here is to really be engaged, right? If I go to the gym in the morning and I want to become more fit, I don't just work out my arms. Right? I might have a great Popeye arm if I do that, but I've only got a Popeye arm. I haven't really impacted my whole body. And that's the idea of not just relying on those Sunday crossword puzzles, but really trying to engage in life fully. And that will help to mitigate that risk that comes along with age. A lot of people hear about a genetic test for Alzheimer's disease, or perhaps if you've participated in a research study or you've gone to different clinical sites, they've asked if you were interested in a genetic test for Alzheimer's disease. That's a real misnomer. It is a test that's looking at your genetics, but it's not for Alzheimer's disease. The fact of the matter is, for this form of Alzheimer's disease that's the most common, there is only one gene on the entire genome, right? We've spent a lot of money figuring out the genome of the human body, a lot of money. And there is only one gene that falls out very tightly to be correlated with your risk for Alzheimer's disease. I say risk because it doesn't say you're going to get Alzheimer's disease. It just changes risk. And when you get that genetic test, it's on the bottom of my slides here. It's APOE, APOE for short. We all have this gene. We all inherit 2 copies, one from mom and one from dad. And it's kind of like ice cream. It comes in different flavors. There's APOE2, APOE3, and APOE4. And whether you have 2, 3, or 4, it kind of modulates your risk for developing Alzheimer's disease at later stages of your life. 2, we think, is protective. It reduces your risk. It's found much less frequently in the general population, so it occurs the least likely that you have 2, but that's what we do believe that the flavor of 2 does. 3 is what is most commonly found in the population, and we don't think it changes risk, either positively or negatively. And then APOE4 increases your risk to develop it. So when you get that genetic test, they're looking to see what your APOE status is. 1 copy of E4 will elevate your risk a little bit. If you happen to inherit an E4 copy from both your mother and father, then in that case, if you truly live long enough, you will have a significantly increased risk for developing Alzheimer's disease. So we at our clinic discourage genetic testing from a diagnostic perspective. It doesn't tell us that you have it or will get it. Because if you look in the general population of people today diagnosed with Alzheimer's disease, they don't all have E4, they don't all have E2 or E3. They're a mixed bag just like all of us are. So until we have a better biomarker than our APOE status for truly telling us when or if we're going to develop Alzheimer's disease, we refrain from using it as a diagnostic or a projection tool. Some of our research studies do include it as part of the test, but that's only for the purpose of the future. If we should find enough medications that are successful in either symptomatic management or disease-modifying management, then we might enter the world of personalized medicine. And if you have different genetic flavors of E4, you might respond better to different treatments. That's the only reason. So, that was a very long answer to a very short question, and the overall answer is, genetically speaking, no, not in the form of late onset. There is a different form. It is much more rare, and it's called early onset Alzheimer's disease. And if there are more than a couple of you in the audience that are living or know of somebody with this form of the disease, I would be surprised. Early onset Alzheimer's disease, the individual begins showing symptoms in their 30s and 40s, and they have the full complement of what we would consider symptomatic complement of Alzheimer's disease by the time they're 50. If anyone saw the recent movie called Still Alice with Julianne Moore, it was a beautiful depiction of what a family and a person going through Alzheimer's disease has. She was very young. She was an academic professor, and she was, I think, in her 40s when she became symptomatic. She had early onset Alzheimer's disease. There was attention paid to the genetics in that movie, and there's a reason for that. We do, in this case, know that it is inheritable. Your Alzheimer's disease is not the result of age or lifestyle. In this case, your Alzheimer's disease is the result of one of 3 genes on 3 different chromosomes. Chromosome 24, 14, and 1. That's really not relevant. But all of those chromosomes, the genes on each of those chromosomes have in common is that they all regulate a protein's production called amyloid. And I bet everybody in the room knows what amyloid is. Amyloid is that darn protein that starts misbehaving. And when it's a very large protein, I think I have a picture of it on the next slide. Okay, it's a very, very large protein. It's that thing in blue that's all wound up here, right? This is what it starts out like. And our body can't really work with it when it's that big. And so our body cuts it up in the second square. You see 2 little scissors. secretases cut it up into smaller fragments so they can go off and do their job. As we get older for some reason, and when we have these particular mutations, we cut it up into a fragment that our body doesn't like. The reason our body doesn't like it is because that fragment is really sticky. The outside surface, when it gets folded up, is really sticky. And it binds and collects junk, other junk like itself and other proteins. And it forms what we call a plaque. And I'm sure most of us are not that's not a new word. We hear about plaque in our arteries all the time. It's not made of the same components, but it's the same idea. It is a physical blocking. It's a physical obstruction in our blood vessels that the blood can't move past. And the same thing happens between the cells of the brain. This plaque forms, and it kind of is like building a wall between the cells of the brain. What's really important is that the cells of the brain communicate kind of like a game of telephone. When we were little, you stood in the long line and you held hands and you started a message at one side and then you passed your message to your neighbor, and at the end you saw how different the message was. The brain is the same way. The cells of the brain, they're called neurons. They're very special. They don't actually touch each other. They get really, really close. And then the way they talk is to send a small chemical message across that little space between them. And that is like squeezing and passing on their message to the next neighbor in the game of telephone. Well, if there's an amyloid plaque wall built right there, how effective do you think that conversation is? It'd be like if I was standing on the other wall and didn't have a microphone, you wouldn't hear anything I was saying. And that's what happens when the amyloid plaques are developed. And so as we get older, naturally, the brain just starts doing this. The processes we have in place to break the amyloid into smaller pieces just don't behave as well, and you start collecting these amyloid plaques. And so that's kind of the first step of the process. And when we have early onset Alzheimer's disease, that starts happening really young in age. And it starts happening because we're predisposed by these genes to start forming plaques. And so that is the form of Alzheimer's disease that we do recommend genetic counseling and genetic testing for. So that's about as much of the hard biology that I'll subject you to, I promise. So as I said, because of the life events, because of age, we get this sort of accumulation of amyloid. Well, the amyloid itself, we don't think is what causes the symptoms of Alzheimer's disease. We know that the brain can't really deal with it. It's kind of like if you have a splinter in your finger, right? Your finger can't really deal with it. It gets all red and swollen, and it's really sore to the touch, and maybe you can't flip your newspaper very conveniently, or if you get like a paper cut, I think I've got one of those here, and every time I squeeze my lime into my drink on the weekends, it really, I feel that. It's kind of what the brain does in response to the presence of amyloid. But the truth is, there are people who have a very healthy cognitive function at the time that they die, who have lots of amyloid in their brain. So we know that Alzheimer's disease is not only the result of the amyloid. But the amyloid sets kind of like, it's the first domino to fall in the long train of dominoes. And so it causes inflammation, and the brain is like, okay, there's these walls. I can't knock them down. I don't have a way to do that. And so I'm just going to start to kind of try to deal with working around them. I'm going to quarantine that wall, so to speak. And so you get this local inflammation and local immunological response that starts squeezing out the cells around it. And that's like, that's not healthy either. So what happens is nothing. That's the end of it. Oh, no, there it goes. So what happens is it starts the domino cascade, and the next domino that falls happens inside the cells. And this is where a protein called tau becomes important. And this is a really complicated slide, but all I want to walk you through understanding is this beautiful guy right here. This is what those cells in our brain called neurons look like. And they're really kind of funky. First of all, they're different than all the other cells in our body. All the other cells in our body look more like this part right here. If you think about what a cell looks like way back from high school biology, it's kind of like a blob, right? Like a little round blob that has a nucleus. But the neurons are really special. They have these really long trajections. And those are what play the game of telephone to communicate their signal throughout the brain. But there's a little bit of a problem with that in that they are physically distant from the worker horse of the cell. All the real good stuff, like the energy production and the parts of the cell that make the cell work, are made here. They got to get way down here to where that communication and the action is happening. And in order to do that, they travel along a railroad track called microtubules. And tau is kind of like the ties that hold that railroad track together. And kind of like amyloid, when we get older, and in response to the inflammation and the presence of those amyloid plaques, that tau protein doesn't do its job of holding the railroad tracks together. And so what happens is the microtubules, those railroad tracks, get all disorganized, and they no longer can perform the transportation in the cell that they need to. And the cell's response to that is, I can't live like that, quite literally. It can't live. And so you get what looks like, if you look in a microscope, you get this tangle. The tubules, the filaments actually look tangled up. And the name isn't anything other than what it physically looks like. The plaque looks like a big physical glomp of goop, and the tangles look like string all tangled up inside the cell. These are the two hallmark pathologies of Alzheimer's disease. We know that if you have Alzheimer's disease, if we were to look under a microscope or use some of the more advanced imaging technology we have now, this is what we have to see in your brain in order to say it's Alzheimer's disease. This is why a correct diagnosis is so important, because you could have just plaque and have no disease. You could have just tau, and you have a disease, but it's not Alzheimer's disease. It may be Lewy body disease, it may be Pick's disease, and the treatment options are very different. So getting the right disease is very important. The tau is what we think really is the shoestring in the cascade of dominoes. It's after you get the onset of tau that we really start to see the symptoms of Alzheimer's disease develop. But you can imagine, I just talked about a lot of stuff. That didn't just happen days before your symptoms. It happens decades before our symptoms. So we're really starting the biological process of Alzheimer's disease in our 50s and 60s, even though we're not seeing the symptoms until late 60s and 70s. And so some of our colleagues have made this illustration for us to kind of show us the pieces that are involved in the biology of disease and put them on a timeline with the symptoms. And it's really quite profound. We know the first thing that happens is that red line, it's amyloid. So across the bottom, we have the clinical stages of the disease. When you are diagnosed with the early stages of Alzheimer's disease, mild cognitive impairment, and then when you have full dementia that is very clear to your doctor, it's very clear to your family members that there's something going on. And then on the left side of the image is your cognitive fitness, whether you are performing in a cognitively normal ability or it's abnormal. And you see the first thing that happens in time is those amyloid plaques form, but you don't have symptoms yet. You start having a difference in brain activity that can be measured by physiological measurements, but you don't really see it impacting like your daily living or your working memory or anything like that. So it's silent. You don't know what's happening. We don't know that it's going on. Then it sets that cascade in motion where we start to get the tau tangles, and you see that in green. And it takes enough of both of those things before we start to see the symptoms. And then we kind of live with the symptoms for a little while, because let's face it, we know a little bit of forgetfulness is normal in older age. I mean, I walk into a room half the time, and I don't know why I've walked into the room. I mean, 2 kids, work, carpools, after-school activities. I don't know sometimes if I'm coming or going. The difference is if I step back and I go to where I was before and I retrace my steps, I can typically bring it around and go, oh, yeah, I came in here because I forgot to, this morning, I came in here because I forgot to put my wedding bands on. So, you can traditionally do that. The problem begins with when you take those extra efforts to try and retrace those steps, and you still can't get it back. That's when we start to go, okay, maybe I should tell my spouse, or maybe I should tell my child, or maybe I should go to the doctor. But that happens a good deal after the disease has already changed our brain and what it looks like. So what do we do at that point? We go to the doctor, we get our diagnosis, and we have a couple of treatment options available to us. We have 4 treatments, but really we have 2. And the reason we really have 2 is because 3 of them all do the same thing. In the top of this table in blue, we have 3 different medications. I've listed both the generic name and the commercial name that you may have it prescribed under. But all 3 do the same thing. They're all acetylcholinesterase inhibitors. So you don't take 3 of them, you just take 1, right? You don't pair your Tylenol and your Advil and your aspirin. They're all going to do the same thing. So we prescribe one of those. Most commonly it's Aricept. And then we prescribe the one in green called Namenda, or the generic name is Memantine. And that belongs to a different family. That's an NMDA receptor antagonist. Neither of those 2 things are important. What's important is understanding why we prescribe both of them together and how they work. So here we have that beautiful picture of what a neuron looks like again. And we have these long extensions that participate in the transport of the signal, right? That's what does the communication. Remember, I told you they get close enough to get comfortable, but they don't touch. So that space in between is called the synapse. And the way in which they talk to one another are through those small chemicals. And so you see these little round packages, those are those small chemicals. They're called neurotransmitters. The cell that's doing the talking in the first place is called the presynaptic cell. The cell that's doing the listening and the responding is the post. We're so creative as neuroscientists. It's the postsynaptic cell. And so the way those drugs work, when the cell releases its neurotransmitter, the first class of drugs, the ones that are in blue, the acetylcholinesterase inhibitors, they stop the process that gets rid of the extra chemical that's been deposited. So it's kind of like if you put too much butter on your toast and you realize there's a big old wad of butter on your toast, so you take your butter knife and you wipe some of it away. But if you're my daughter, you just let that sink in. Because she really likes salted butter. I mean, she's like a deer. She'll just take it and lick it off of the stick. The more that's there, the better. So the acetylcholinesterase inhibitors stop our body from getting rid of the extra chemical that's been deposited. It's kind of like if I talk to you from over here, or if I talk to you from over here, you can hear me better. That's basically what it's doing. It's like putting a microphone up to the conversation. And then the drug here in green works on this side. And it makes the receptors, it makes the things that are doing the listening and binding those chemicals work better and take up the right chemicals as opposed to the ones that are going to dampen the conversation. And so now, not only am I talking with a microphone, but you've dialed up your hearing aid. Okay, so that's what those 2 drugs do. Now, have I said the word plaque at all in describing what these drugs do? No, I haven't said the word tau either, but we know plaque and tau those are bad guys in Alzheimer's disease. So these drugs manage symptoms, but they do nothing to stop or regress the disease from moving forward. This is where we are today. This is why we have symptomatic treatment in some people for several months, and others a couple of years. But that's because the disease is moving forward in the background in spite of taking these treatments. The truth is, if you or I took these drugs, we'd be working a little bit better. We would get a cognitive boost. And in fact, we prescribe some of these medications to people who are cognitively perfectly fine. In the military, they're engaged in vigilance tasks for long periods of time. They need heightened attention, concentration. Sometimes pilots, for example, who are doing multiple transatlantic flights and need heightened state of concentration and vigilance for a long time, they take Aricept. It gives them a little bit of a cognitive boost. But what's important is that these diseases, while they are approved by the FDA, while they're approved by the FDA for the treatment of Alzheimer's disease, they are symptomatic treatments. They're helpful, absolutely. And the earlier you start taking them in the disease process, the more helpful they are. Because what happens is what we're looking for as an outcome is a stabilization of the symptoms. We know the disease is progressing in the background, but we're looking to kind of plateau, to stop what we're seeing as a symptom of the disease for a period of time and to slow that rate of decline. And so a lot of times we prescribe these medications, and let's face it, they're expensive. And after a couple of months, our family members come back to us and say, we've had to stop giving it to Pop because it's too expensive for not working, quite frankly, and we're not seeing an improvement. And that's one of the first places we have to educate our families, is that it's not going to necessarily improve the performance of our loved one. It's going to reduce the rate at which that performance is going to slip over time. And so unfortunately, what we see sometimes is they do take their loved one off of the medication, and then they see a rapid decline in performance. And then they go, oh God, it was working. We got to get them back on. The problem is, then when we put them back on, we don't gain that function back. We've set a new plateau. So it is really important, and I don't say this with any affiliation with any pharmaceutical company that is making money off of these drugs. It is really important to discuss very seriously with the physicians when you decide to take a loved one off of the medication. Sometimes it is right. There are some side effects, particularly to Namenda. We know those side effects with gastrointestinal distress, but a lot of times there's time of day that could be changed. There's combinatorial therapy options that try before you just cold turkey go off. Because like I said, you won't gain that function back by the time you realize it may have been doing something. So I don't want to paint abysmal picture, and I by no means mean to. They are meaningful symptomatic treatments, but we must do better. We must do better. And this is where I can inspire you quite a bit. We have 35 active clinical trials as of February of last year. 35 active clinical trials that are looking at new medications to treat the symptoms of people already with Alzheimer's disease. These are people with mild to moderate or severe Alzheimer's disease who are taking things like donepezil, Aricept, and Namenda, and maybe have exhausted the efficacy of those medications. And so these are new options that are in the various stages of clinical trial. You see them here, 1, 2, and 3, for FDA approval for the treatment of the symptoms associated with Alzheimer's disease. Some of them are to treat the cognitive ability. Some of them are for behaviors that you want to mitigate. And others are in the form of regenerative medicine. That's kind of science fiction to me still, I got to be perfectly honest with you. But there is one out there that is in a quite advanced, it's in phase 2 clinical trials. What does that mean? Phase 1, phase 2, what is she talking about? I kind of hoped you'd ask. So phase 1 is the first stage of a clinical trial. This is where we take a medication. It's most often something that hasn't been put in a human body before. And there's a small number of volunteers, like 10 or 20, and they're healthy. They don't have the disease state that we might long-term be interested in. And we give them the medication, and the goal of this phase of a trial is to determine how safe and tolerable that medication is. What is the metabolics of that medication? How quickly does our body deal with it and get rid of it? How bad are the side effects? Is it safe? And at what dose can we push it to before it becomes intolerable? And that's what a phase 1 clinical trial is, and as I said, the success is determined on its safety profile. Once it has demonstrated safety in that population, we'll move to what's called a phase 2 clinical trial. And a phase 2 clinical trial is a slightly larger group. Now maybe we have like upwards of 50 people. This time it's a group that does have the disease that we are looking for that treatment to have an impact on. And again, we are looking at safety and tolerability. And we're trying to figure out what is the dose that is going to be necessary to impact either a symptom or the outcome we're trying to impact, to improve. And so this is when we introduce the placebo. Does everybody know what a placebo is? This is the sugar pill that, a lot of times we sign up for a clinical trial thinking we're going to get access to something new, and then we find out 3 years after we've been taking it, it was a sugar pill. And I share your frustration at the time. There is a real important reason we do that. The reason these tests are placebo-controlled is because there is a 20% on average improvement in that population of people who were taking just the placebo and didn't know it. So this is that mind over matter. This is that piece where, because we believe we're doing something good for ourselves, our body responds. And that is absolutely why we have to do the placebo control, because we actually need to see that these drugs are working beyond what the placebo control is working. It's not because your doctor doesn't like you and likes the guy next to you better, so he gave her the drug and he gave you the placebo. We are blind. The gold standard not only is to have a placebo control, but it's to be randomized and double blind. Randomized means I don't decide who is in the trial, and I don't double blind means I don't decide if you're getting the drug or you're getting the placebo. The part of the expense of these trials is making the placebo look like the drug. If it's a liquid you're taking, we make the placebo look exactly like the drug. So we don't know when we're dispensing it if I'm giving you the placebo or I'm giving you the drug. It gets really hard in some of these trials, like the methylene blue trial. Methylene blue, it was a phase 2 clinical trial, and making a placebo for that guy was really hard because methylene blue tends to make it look like a Smurf after a while, after you've been taking it for a while, turns your urine all kinds of fantastic colors. So I'm not really sure how they worked out the placebo for that one, but nevertheless, that is phase 2. And then if we've seen that it is, again, tolerable in the population who have the disease, and it looks like it's making an impact beyond the placebo control, we move into the big boy. This is the really big clinical trial. This is the one that takes lots of money because it takes lots of people. These tend to be multi-center across the country. We're engaged in a number of these where there are 15, upwards of 30 sites involved in the clinical trial. This is where, again, we have a double-blind, randomized placebo control, and we are looking at the size of the impact that the drug is making on the outcome that we're measuring, whether it be behavior, cognition, or regeneration. And these are the data that we have to then present to the Food and Drug Administration to make sure that for them to determine whether or not they're going to allow it to be approved for commercial distribution. So of all of those medications, though, I told you there are still symptomatic treatments. They're not doing anything still that are disease modifying. We're not addressing the amyloid, we're not addressing the tau. And so if we ever want to move into the age of prevention, that's what we have to do. Because we know that's happening on this curve. That's happening years, if not decades, before our symptoms are happening. And, well, we're not going to the doctor until we have symptoms. We don't know that it's happening. So, we need better biomarkers to start testing ourselves in our 50s and 60s with to see if we are developing amyloid or we're developing tau. Because then we know we're on a trajectory that in 10 years we're probably going to have the symptoms. And then we want to interfere with that amyloid production and that tau disorganization so that we never get those symptoms in the first place. That's prevention. And that's surprisingly where I'm pleased actually to say, after 120 years since Alois Alzheimer first diagnosed an individual and described what Alzheimer's disease was, we are there. This is within grasp. This is what Alzheimer's 2020 is all about. It starts with early identification of people who are at risk, not by, quite frankly, a genetic test that tells us, well, kind of you have a little increased risk and you've been a smoker, so we're going to guess. No, this tells us with imaging in the live person, not under a microscope after we've had to look at the brain under a microscope, which is kind of hard to do when it's still inside your skull. This is in a living person, decade before symptoms. We can see amyloid with the instrument called a PET. That's actually right here, and I purposely put a picture up on it because it's not as scary as an MRI. It's certainly not as claustrophobic. It doesn't make that loud knocking sound. You lay there very comfortably, and we take a picture. We give you an injection. And basically what we're giving inside your body goes into your bloodstream and it goes up to the brain. And it's an antibody. And it's an antibody that has been raised against amyloid. So it doesn't go anywhere in your body and stay unless it finds amyloid. That's what it binds to. That's what it sticks to. If it doesn't find amyloid, you just pee it out. But if it finds amyloid, it sticks to it for a while. And then when we put this machine we take a picture with this machine, it lights up where that antibody is bound to the amyloid. So the pictures that you see are kind of like the radar of Florida in July. And that's how you can think of it, right? You know a storm is a-raging when that baby is yellow, red, or orange. And that's basically what you're looking for in these pictures. If you have an amyloid positive brain scan, then you're seeing regions of the brain light up in yellow, orange, and red. If you have an amyloid negative brain scan, then you're seeing predominantly blue and purple. So now we have something that, just like our colonoscopy, just like our mammogram, we can do prophylactically at an earlier stage in our life to say, where am I in this domino cascade? Am I starting to develop amyloid? And if I am, well, gee, what are you going to do about it? And now we have something we can do about it. We have a number of medications that are in advanced stages of clinical trial. These are in the phase 3 clinical trials that are actually showing that they can reduce amyloid in the brain. This is like, if I asked by showing, please don't raise your hands, but if I asked by a showing of hands, how many of us are on a cholesterol management treatment? I bet there would be a pretty large percentage of us that would raise our hand. Lipitor, Crestor, whatever it is. We go, we get our cholesterol checked. We know that it's high, so we take a medication to reduce it, and then hopefully we avoid stroke and heart attack. We don't wait until the stroke and the heart attack happen to start taking these medications, but that's essentially what we have available for Alzheimer's disease. And we've got to get ahead of that. And that's what many of these, if it's labeled as disease modifying, that's the goal of these medications. They are addressing early stages and prevention. They're getting ahead of amyloid plaque development. They're getting ahead of tau development. Or their goal is to reverse it and get rid of it once it's been started to accumulate. And we have evidence that this is possible. We have evidence now, not just by anecdote, but we have data that shows when we give an agent that reduces the amount of amyloid, it doesn't just stop the production of amyloid in its tracks. So what this graph here shows is we start giving the medication to people all at the same time at the same stage of the disease. And every several months, we check in with them, and they keep taking the medication, right? Every several months, we check in with them. The blue line is the placebo, and it shouldn't surprise anybody that it continues to increase because the amount of amyloid continues to develop as the disease progresses. But the red line are the people who were taking the active drug. And the red line doesn't just stay flat, does it? If it just stayed flat, we'd be satisfied because we stopped additional amyloid from aggregating. But over time, it goes down. It goes down because not only does it stop additional amyloid formation, but it looks like it's getting rid of, it's helping the body find a way to get rid of the amyloid that was already there when they started taking the drug. This is really breakthrough. This is where we believe we're so close to having this kind of treatment approved that in 2020, this is a possibility. So Alzheimer's 2020 is at an earlier stage, around 60 to 65, you would go and have your PET scan, and we would determine the amount of amyloid in the brain. In addition to, now that drug is already FDA approved. We already have approval from the Food and Drug Administration. We know it is safe, and we know it is sensitive and specific to detect Alzheimer's amyloid in the brain. But if you recall, I did tell you that amyloid is not the only thing that leads to Alzheimer's disease. It's the first step, but it's not the only step. We need tau as well. If you're positive, then we want to know, okay, how far into the cascade are we for Alzheimer's disease? Then we would follow that up with the tau scan. And that is what we're in clinical trials to do. The same way we determined that the amyloid agent was safe and sensitive and specific to amyloid, we're in those studies right now for tau. So we could then follow it with the tau study and say, you are at a point where we need to treat you with both an amyloid and a tau reducing agent. Or you're not at that point, we just need an amyloid treatment. So for those individuals who do test positive, we've got all of those. I can't remember what the number was on the slide here. Yeah, we've got 23 right now in phase 3 clinical trials. We've got 50, and if even a third of those move on to phase 3 clinical trials, we have a pretty good number there for clinical trials of treatments that are potentially disease modifying. Then we would prescribe one of those treatments, and the goal there being that you're not going to get the symptoms in 10 or 15 years. And then those options that would affect the population of individual who's coming up to the next generation of Alzheimer's disease. The individuals who have Alzheimer's disease now have the benefit of those, I think it was like 23 or 17 trials that are currently symptomatic management in advanced clinical trials. So for those of you in the room who are wondering, or came here wondering, is this what because I have, or a family member has Alzheimer's disease, is this what my kids or my grandkids' future is going to be? Is that my legacy? This is really where you can make the legacy. What you can do is participate in research. What you can do is advocate to loved ones to participate in research. I know that there is that pesky placebo control, but if a drug is shown to be effective in phase 3 clinical trials, then the majority of the time they move to an open label trial. An open label means that if you were on the placebo control to begin with and you contributed to that research study as a placeboed patient, then you get access to that treatment before it is made available commercially to the public and you have to pay. You get the same access to that treatment as those who were in the treatment arm. So those clinical trials that go to open label, that's because they were shown to be effective against that placebo control, and you get your fair shot at that medication. So, couple of things. What could my legacy be? This is a really, really important slide. It's a busy slide, I realize that, but it's really important. It's really important to see those circles at the bottom, because Alzheimer's disease today is claiming nearly as many lives as heart disease does and as cancer does. And if you look just above it, the cost of managing Alzheimer's disease exceeds that a lot to cancer and quite a bit to heart disease. But then if you move over to the next panel and you see the research funding, it is woefully neglected when you consider the context that it is as big and devastating, if not more so economically, as heart disease and cancer. But cancer gets 3.5% of its medical costs funded in research. Heart disease gets almost 2% funded in research. Alzheimer's disease, you need a decimal point. We are at 0.03% of our research, of the actual cost to manage the disease that comes back to us in research dollars. And I don't mean just us. This is the National Institutes of Health funding statutes that I'm showing up here. That is what they have to allocate to Alzheimer's disease. So if you wonder what your legacy is and maybe your clinical trials are not for you, then please beg, write, plead, call anyone you can get your hands on locally at the state level and at the national level, and make Alzheimer's disease a priority legislatively. They're starting to get it. Well, let's be honest, they're older. They're scared. They should be scared. And they're starting to get it. And so that at the national level, there is an act. There is an act to raise the federal budget for Alzheimer's disease. But that doesn't work if we don't have a budget. So tell your congressmen to do their job and get a budget resolution. So that's the second thing I ask. Finally, at your local level, I mean, you're all here, you all know the great work that Maria and her team and your first responders and the city of Seminole's commitment to being dementia friendly and the Purple Ribbon campaign, you've already taken those steps. What I ask you to do is talk. If someone stands still long enough, talk to them. Tell them what it is like to go through your activities of daily living with Alzheimer's disease. Some of you, I think, are going to see a presentation about, or all of you, if you stay, are going to see a presentation about what that is like for the patient, so that you can understand when we give you behavior strategies of entering their world or entering their reality, what that means. tell anybody who will stand still long enough and listen, because we really, in Florida particularly, we need to make it a priority. So bugging and nagging your legislators, I've seen it work. I know it works. I've been to Congressman Jolly's office, and I've been to town hall meetings where I know this part of Florida is very interested, and they just need to keep hearing from you so they can keep raising it and moving forward. They will represent you if the voice is loud enough. And then if you have friends who have means, tell them to donate. Tell them, and I'm not saying just to us. There are great the organization that is sponsoring this conference, the Alzheimer's organization. There are a number of them: Alzheimer's Family Organization, Alzheimer's Association, the Institute. From a research perspective, everybody has their role, whether it's to improve the life through research, improve your opportunities through services and respite, through education and dissemination of knowledge. Unfortunately, there are not enough grants for us to apply to make Alzheimer's 2020 a reality. So the more that you can lobby on behalf of yourselves and your family members and your kids and your grandkids, that can be your legacy. So I think I'm up. I think I tried to do really well with time. I think I'm up to my time limit, but I have about 5 minutes that I'm happy to entertain questions. I'm going to say in advance, though, that for a variety of reasons, for privacy and the fact that I know a heck of a lot about mice, much less about people, because I am a PhD and not an MD, please don't ask me personal diagnosis or medication questions. But other than that, I will do my best. And I think we have a microphone coming around.
Dementia.
Yes. It's a great question, and I'm sorry that I didn't include it in my slide deck. So if you think of a pizza pie, and your pizza pie is dementia. Dementia is what we call a group of symptoms. Kind of like we say you have a cold. You've got runny eyes, itchy throat, sore, maybe a headache, but that's just all of your symptoms. And dementia is the same thing. Dementia is a group of symptoms. It's an umbrella term for the symptoms of having issues with short-term or working memory, of having issues with, I'm having it right now, where you can't think of the word, apraxias, you can't think of the word, or you want to feed yourself, but you can't commission your body's executive function to do it. It's having absences of knowledge of where you are in time and space. We all know this, our loved ones mistake us for ourselves at a younger stage in life, or our husbands for our children, or our children for our husbands, vice versa. It's having potentially hallucinations or delusions. When you have this cast of symptoms, then we term it dementia. But dementia is not a disease diagnosis. Lots of things can cause dementia. So if you take your pizza pie and you cut it up into slices, I want the slice that's 60% of the pie because I like pizza, especially if it has mushrooms on it. That's the slice that is caused by Alzheimer's disease. By far, it is the leading cause, diagnostically speaking, of dementia. But let's not discount the other 40% of the pie. It can feed a lot of people. It's important. And importantly, it may have treatments that are even more effective than what we have for Alzheimer's disease, so you need the right diagnosis. We know that vascular disease causes dementia. We know that depression and even some different forms of substance abuse can look like and cause features of dementia. We know that nutrition imbalances, like a variety of things like our vitamin B complexes, folic acid, folate in our diet, those, if we are malnourished in those nutrients and vitamins, that we can have symptoms of dementia. Some other things, systemic infection. A lot of times our older adults in assisted living and nursing homes who have recurring urinary tract infections, and they don't have it with pain, you can get delusions and you can get symptoms of dementia. So dementia is not Alzheimer's disease. It's not the same thing. Dementia is a term we use to describe a symptom collection. The disease that causes those symptoms, 60% of the time, if not more, is Alzheimer's disease. And there are other diseases as well that can cause dementia. Sometimes in our loved ones, it's actually a mix. We have vascular and Alzheimer's disease, or we have, depression and Alzheimer's disease. So having a specialist or a physician, even a primary care family physician, who really is taking the time to do a proper diagnosis is very important, because some of those things I described are perfectly reversible. It's a great question.